Silicone oil is used frequently in the management of complex retinal detachments with proliferative vitreoretinopathy, giant retinal tears and multiple tears. For a typical surgery for PVR, a thorough vitrectomy is carried out. Peripheral vitreous cleanup is meticulously done. Perfluorocarbon liquid is used to stabilize the posterior pole. Epiretinal membranes are identified and removed. Endodrainage is carried out to flatten the retina. Retinopexy is achieved using endolaser and silicone oil is injected. Once retina is well attached and remains stable post-operatively, silicone oil is removed at around 4 to 6 months. Sometimes during this period, the retina may redetach. It might be due to reopening of breaks or inferior reproliferations as the tamponade effect decreases in that area. These subsilicone oil detachments can present a unique challenge to manage. Case 1 has redetachment under oil with epiretinal membranes. Here, subsilicone surgery is undertaken and infusion is kept on air. Membranes are removed using a forceps. Fluid is aspirated passively from an underlying break. Endolaser is carried out. Case 2 presented with a redetachment with thick membranes. Here we start with injecting perfluorocarbon heavy liquid to assess the traction and support the posterior pole. Once again, we are working under oil. Epiretinal membranes are peeled meticulously. PFCL is then aspirated using a soft tip cannula. Following that, subretinal fluid is drained. Once retina is flat, endolaser is done. After this, further silicone oil is injected. Case 3 presents a situation which has a large inferior break. In this situation, one has to remove the existing silicone oil and keep infusion on regular fluid. After that, perfluorocarbon liquid is injected to flatten the retina. Epiretinal membranes are removed. Extensive inferior endolaser barrage is done at the end. In case 4, there is extensive contraction of the inferior retina. PFCL is injected. And membranes are delaminated using a spatula. Persisting traction is further released with a relaxing retinectomy. endolaser is carried out. At the end of the procedure, the small gauge cannulas are removed with minimal trauma to the underlying conjunctiva. Case 5 has subsilicon slippage of flap of a giant retinal tear with extensive shortening. Once again, the existing silicone oil is removed. After that, the contracted edges of the flap are teased and traction is released under PFCL. Relaxing retinectomies are carried out. Once retina is flat, endolaser is done. Silicone oil is re-injected. Case 6 has a detachment with subretinal silicone oil. In this situation, PFCL is injected to displace the subretinal silicone oil towards an open break inferiorly, and then the oil is gradually aspirated. After that, a relaxing retinectomy is done to relieve the traction. Endolaser barrage is carried out. Thus, even in these slippery terrains of subsilicone oil retinal detachments, one could achieve satisfactory results.